Hello and welcome to the second event of Patina's Community of Practice for the Healthcare Industry. I'm your producer, Jeci Casperson, Community Manager at Patina. We're so happy so many of you could join us from across the U.S. A few housekeeping items before we get started today. At the bottom of your screen, your controls should look something like this. Bottom left-hand corner of the audio settings, if you can hear the audio, you're all set. You have a chat tool, the raise your hand tool, and a Q&A tool at the bottom today. I won't ask you to raise your hand. I can't hear or see you. So if you have a question or comment for our speaker, simply use the Q&A tool. This is where we'll handle all questions and comments. We'll have our speaker address these questions as time allows, but feel free to reply to others or upvote questions you'd like to hear answered by simply clicking the thumbs up below the question. That signals to us that this is a popular question that we want to make sure the speaker addresses. If you haven't downloaded Zoom and are using the browser version, you may not have access to all of today's features, but you should be able to watch and listen. If you have any technical questions, please use the chat tool to communicate with our production team. Please do not use the chat tool to communicate with our speakers. At the top of the window, you'll find view options that you can use to change the viewing of today's presentation. Today's event is being recorded and a replay will be available in the coming days. We're constantly trying to improve our events, so watch for a post-event survey today, and if you complete it, it will help us make this community of practice even stronger and richer for all of you. With that, I'll turn the event over to Mike Harris, CEO of Patina Solutions.
Thanks a lot, Jesse, and welcome everyone. We expect to have a couple hundred talented healthcare executives from throughout the country on the call today, and many more will listen to the recording later on, so yeah, you're in good company. Patina continues to make great progress in building our talent community that's designed for independent executives like you, and we call it Patina Nation, and we're glad you are a member. We have many valuable offerings for you at patinanation.com, and that includes learning and development programs and high-quality benefits such as a 401k plan and soon a group medical plan option, even if you have not worked for Patina. And we also have a variety of business support services like an excellent IT help desk, and we have proven in marketing sales tools. And then coming soon, we're excited about Patina Connects. This will be the opportunity for all of you to be able to talk with each other, and we think it's going to be exciting and helpful. Today is our second healthcare industry practice event, which is designed to help you stay current and connected. And our goal at Patina Nation is to help you be the best independent executive you can, whether you're working for yourself, working for Patina, or even working for our competitors. So with that, I'm going to turn it over to Deb Gordon from Patina, and Deb is going to take it from here.
Yeah, great. Thanks, Mike. Our guest and thought leader joining us today is Mark Head. Mark is the president of MDH Consulting and an expert on Psychlytics to increase patient engagement. Mark has over 30 years of experience in the healthcare industry, and I'm excited to hear from Mark today to learn about Psychlytics and how implementing a human-centric model of healthcare improves patient results and also saves money. So Mark, thanks for being with us today.
Yes, thank you. I appreciate the opportunity. Just confirming you can hear me.
Sounds good.
Okay, great. So I'm going to go ahead and share my screen then. And you should be able to see the introductory slide. Are we good?
Yes, we are on my end. Thank you.
Okay, thank you. I just wanted to be sure there. So, okay. Thanks everyone for your time today. My background includes time as a benefits consultant and time in the health management industry, so I've been around the healthcare field for well over 30 years, and all of us are grappling more today than I think perhaps at times past for how do we get our patients more engaged with all of the things that are available to them and that we need them to do for their best health and our best clinical outcomes as well as financial outcomes. So a relatively new development in the healthcare and benefits field that goes to how do we connect to that human being who is playing the role of patient in their lives. Of course, they've got lots of other things going on too. And so when we can connect to them based on the way that they see the world, their worldviews, their values, their beliefs, and priorities and preferences, this is what is called psychographic profiling. It's part of the overall field of behavioral science. And what we're able to do with psychographics is to understand the way to communicate with that individual human being so that they hear the message by kind of transmitting phrases and keywords that are connected to their values and that already are what they're listening for out there in the real world, if you will, so that when they hear a message that already is including words that they value, they perk up because that message stands out in the cacophony of things that are being pushed to us from every media source we can think of these days. And so as we think about the healthcare system and patient engagement, really what drives patient engagement is the patient having a good experience. And it just was such an amazing development over the last few years as we see new entrants coming into the healthcare field that I wouldn't really have expected, say, 6 or 7 years ago, which speaks to how fast this is changing. And when you think about Amazon and Jeff Bezos and Warren Buffett, the venerable investor, and Jamie Dimon out of the banking industry, creating this new approach to healthcare and attracting significant talent, and you think about what is beginning to get connected, and in many respects is already here, the connection between the facility groups and the physician groups that are working with our patients is now happening outside of the office as they go about their daily lives with apps and other messaging that's being pushed out. And so this construct of needing to really amp up the patient experience, comes from the development of the way care actually is delivered, whether we're still doing fee for service or we're moving into value-based care and risk contracts. Here, we have to have population health to make risk contracts work, which requires the patient engagement component, which is dependent in turn on the patient experience. And this has evolved as we have seen healthcare from the time I was in my teens and HMOs came onto the scene all the way through to Obamacare and this risk contract mechanism that's becoming increasingly prominent and shows no signs of diminishing over the next few years. And I suggest that this, to use a geological metaphor, is like the tectonic plates on the continent shifting, and it's really building pressure that is creating a new environment in so many new ways. So it's not just Amazon and JP Morgan and Berkshire Hathaway getting into healthcare. We now see, CVS buying Aetna. We see United Health Group buying provider groups with Optum and DaVita. So this kind of pressure continues to build at a very foundational level, and it's disrupting change and causing change for every stakeholder in the mix, and everyone is affected. So if we think about where we are with the physician and hospital side of the equation and the flow, if you will, of the experience of this human being as they come to encounter the healthcare system over here, as a physician's patient, that's the way the physician engages with the human being. But the human being spends far more time engaged with their employer in the role of employee and far more time living their lives engaged as a consumer. And to some degree, they really only care about their role as a member of the health plan when they need health care. And by that time, we may have seen the employer's programs to support well-being and culture, underpinned, and the consultant is usually invisible to that human being, but they're heavily involved with the employers in sourcing the health plans, a big part of which these days, as we all know, are understanding the discount analytics of, network A or payer B versus the other ones, the BUCAs in the world. Everybody's doing these discount analysis, which are driving a lot of the employer decisions, and of course, in turn, drive the allowable charge, which comes through to the providers. And then you layer in risk contracts on top of that, and this cascading influence really is, in my mind, to keep up with this metaphor, and then we'll move on, is what side of the fault line are we going to be on? Because there are going to be people who are winners and people who are losers. And I think the ones that can successfully migrate from the current state, where patient engagement continues to be a systemic challenge, to the plate that's rising up and can engage patients more successfully, more consistently. Doubt we'll ever get to full patient engagement the way we'd all maybe like, but if we can improve it by even a few percentage points, that I think is a prophylactic measure for who is going to survive and not either be gobbled up or ultimately not be able to make it in the long term. So we're going to spend the rest of the time talking about the psychographic model that's been built specifically for healthcare and benefits. And they've built a 5-segment model, knowing that when we've moved in the past to analyze patient data and target people for interventions, outreach, population health, medication adherence, even things like patient acquisition and loyalty, and how do we keep that patient coming back, and how do we collect from them in a more efficient way. We've worked off of EHR and demographic data as the primary ability to understand that human being's encounters with the health system. Of course, that's not all that those people, those human beings, are doing. And so the new world with patient personas is not leaving behind the data. It's basically evolving the data so that we now have an understanding of the values of that human being, and how do they perceive healthcare, and what do they believe about the way they live and move and breathe in the world, including do they prefer print or email or text or app or portal or voice-based contacts. And the different health personas actually have varied preferences in the way that they would rather receive communication. So that can be an important factor in creating a better patient experience, which is, part of sustaining patient engagement over time. And part of this psychographic profiling brings in the intelligence that the advertising industry, the marketing industry, and more recently, the web-based data that's being harvested by the Amazons of the world and Google tracking our search engine behavior, et cetera, et cetera. And I remember some, not that long ago, but a few years back, I was doing a search on Google for cowboy boots because I was going to go to a party, and I logged into Amazon, and there were ads for cowboy boots, like within 10 minutes. And it was a kind of an astonishing thing to realize that this system, this data system, and this electronic tool that I was using is also surveying me and keeping up with what I'm doing. So when we can combine our understanding of the patient's clinical situation with their broader human situation, then we're able to create this better patient experience. And we can move beyond what has tended to be a one-size-fits-all message for a group of patients that we've identified for a specific purpose. I'll use diabetics as an example, horrible disease, number one cause of blindness and kidney failure and all the things that we know about. And we're now up, hovering around, depending on which population you look at, 7 to 12% of the adult population we may identify as our diabetic targets, and then we would send messaging to those diabetics based on what we know a diabetic needs to do from a clinical management standpoint. And those messages tend to be what I call linear. They tend to be instructive, educational, how it works, what it is, what you need to do. And the inference is obviously you're doing this because you want better health, and all human beings have a clear awareness that our quality of life is linked to our quality of health. So understanding what's being asked of us is really important, but we know that we've kind of maxed out on the engagement rate. And so when we can create this better experience by tailoring a message and speaking to that patient's values and beliefs, we don't let go of the underlying educational portion. We're adding in whatever we can that triggers the why that human being would want to do that. So I happen to be a balance seeker, and I am proactive about health, but I want to make my own decisions. And I like research. I'm going to look at everything I can find on the internet. I'm going to talk to friends and anyone who I believe has more expertise than I do. And I'll go to the doctor kind of when I feel like I need to, but I want to try to handle as much as I can by myself on the front end and manage my health that way. The self-achiever segment, who is the other proactive segment, will generally go to the doctor as a first response. They don't want to spend the time doing research. They're less concerned about a lot of options and counseling. They want to go to the expert who can tell them what's wrong very quickly and distill it down to a measurable set of actions that they can track and turn into a goal so that they can be in charge of that process. And we'll talk a little more about some of these other segments. But Jeci, at this point, I'd like to put up our first poll question. So as we're thinking about where we are today, let's have everybody take a few seconds and answer the questions here, and that'll give us a pulse of the audience, and then we'll keep going. Well, this is great to see this in real time. We'll give it just a few more seconds. Be great to have more people answer. We've got about 50, a little under 50 responses so far. But yeah, the number one response, 60%, 2/3 are somewhat well, but we're struggling, or not very well at all, and only about 1/3 are saying moderately well, and we're taking action and have an emerging plan. And nobody's saying they're doing very well and ahead of the pack. So that's pretty interesting. So let's share these results. And as you can see here, you know, we're 2/3 are on the bottom half, and only 1/3 in the upper half, and none at the top. So thank you for that. I think that kind of tracks the general experience that many of the people that we're talking with have. And I'll keep going here. So let's, okay. So as we think about moving beyond the one-size-fits-all message to tailored messages, and we're looking at a 5-segment model, I'll take just a couple of minutes and talk about how we're able to bucket people into one of these 5 health personas. And I'll talk a bit about the research model as well. This was developed by a couple of guys that came out of the Procter & Gamble Healthcare Institute, and they had been doing consumer segmentation models for over 20 years. They realized with Obamacare coming down the pike that there was going to be an increasing emphasis on consumerism in healthcare. And so they created a healthcare and benefits specific model and went out on their own and worked with a global research firm. There have been about 15,000 people who've gone through the research model, answering over 400 questions apiece on average. And all of the data was crunched by data scientists using cluster and factor analytics to develop a 5-segment model as having maximum differentiation among the 5 segments while preserving maximum internal consistency within each of those 5 segments. So these are very distinct segments, and the reasons that the proactive types, as I am a balance seeker, and the proactive self-achiever will do something, even though we're both proactive, the reason why we do that is very different. And then the ones that are more reactive require a more creative approach. So when we're working with individual patients and we have some engagement going on, we can use a 12-question classifier at the individual level that will bucket someone with very high accuracy. But we've also taken this body of tens of millions of research data points, and the data scientists did a very comprehensive project with consumer data and basically matching up the consumer profiles of all of the research participants. And then they were able to say all of the people who are balance seekers have a statistically correlated consumer profile that is also statistically differentiated from the consumer profiles of these other 4 segments. And so that working with this national database company, we now have a statistical projection for a health personality segment on well over 200 million Americans, and will typically match about 80 to 90% of the records on a patient file that allows us to start a campaign after we're able to reanalyze our population to know for our diabetics, well, which ones of our diabetics are balance seekers and which ones are willful endurers, et cetera. And, you know, better than a 50-50 chance that we're connecting with them at the level of their values and beliefs. And so this is really beginning to move the needle in an important way. One of the places this has been deployed is at Tri-Health Corporate Health in Cincinnati. Carrie Hanlon is the COO there, and this was in Hospitals and Health Networks magazine from a couple of years ago. They started with about 3 diabetic nurse coaches, and now they're using this system-wide. And she gets this idea that if we want to motivate people to really follow the treatment course and receive the support that's available to them on a consistent basis over time, then we've got to give the balance seekers choices, and we can't be telling them what to do. But with direction takers, they need to be told what to do, and they'll generally go with it. The challenge with direction takers is often that they find a treatment plan complex, or they get busy, and so they need a lot of hand-holding over time. But as long as they can stay connected to the physician, they'll generally go ahead and do what's being asked of them. Willful endurers are the most reactive group, and there's an art there because they live for today. They don't believe in investing time and effort and money today in order to have better health tomorrow, generally speaking, and they'll just deal with tomorrow when it comes. And priority jugglers are something of a mix. They tend to be reactive about their self-care because they're putting their number one priority on their family, and then they also have a sense of duty and loyalty to colleagues and work second, so they tend to put themselves third. So they're a group that will do what you want. They are often highly educated and high income earners. A lot of executives are priority jugglers, but they'll still tend to put their own health third, so you remind them people are counting on you, and that will tend to remind them that they do need to put themselves first. So if we think about this idea of patient engagement as being the keystone, and we think about a cascade, if you will, of wanting to ultimately get to where we are reducing clinical treatment costs and maybe even increasing revenues, improving all of those things are dependent on having more people engaged. And you can use the term enrollment, or at least coming in for, episodes and encounters with the physicians and the specialists, and hopefully avoiding the high cost inpatient episodes where we can. But to get them in the door and saying, I'll do something, requires that they respond. It could be responding to a phone call or a direct mail piece, or an email or a text message or an app, or trying to get a patient portal registration completed. All of those are dependent then on the messages that they're receiving. So this actually becomes, in a very real sense, the maximum leverage point that ultimately, if we can increase the number of people responding to messages, that increased volume coming into the top end of the funnel, or the bottom end, in this case of the stair steps, is what we need to get, so that more people ultimately make it up to that level of improvement that are driving the KPIs that we're all looking to improve. So I'm going to go through this next section pretty quickly. You may be familiar with the golden circle concept developed by Simon Sinek, but we tend to, in our messaging, whether it's patient messaging or employee messaging from an employer, or even out in the broader market, the consumer messaging tends to start with what it is we're doing or asking, and we want people to come see us, and we've made it easy. You can schedule online or call in and schedule, and of course we want you to be healthy. But if we start from the other end of the spectrum and go from inside out, try to connect down at that gut level of what motivates that person, and we were to say, well, if you like being in charge of your health, or if you like choosing your path to better health, we've got a program for you, and come see us and let us show you how it works. Well, that begins to connect immediately to the proactive self-achievers who want to be in charge of their health, and to the proactive balance seekers who want to choose their path to health. But that's about 2 out of 5 of the population at large, and that type of messaging doesn't appeal naturally to these other 3 segments that are 3 out of 5 of the general population. So we've got to have a different tack for that. I don't think this is the only reason we see stats like this. Money obviously is a huge factor with high deductible health plans, and collections have become a challenge, and revenue cycle management a challenge more today than maybe 10 years ago because of that. But also just not hearing the message and not responding to that, and we've got to get better than that. So if we can transmit on that frequency that someone is listening for, if we're transmitting on the classical music station and we're trying to connect to somebody who listens to country music, we're not going to get them. So it's maybe not that precise, but when we can infuse these messages with the why, we're beginning to bridge between the gut feeling that this is right for me, it feels good, and it's logical. So we've got both of those, which behavioral science say this will trump this as often as not, and maybe even more often. So I'll give you an example of what we might do with this. We would tend to send, say, a text message or a voice message reminding a patient to pick up their meds. It's time to pick up your prescriptions. You need to do what your doctor says. Stay on track. That resonates with direction takers. But what if we used a Nike kind of let's do it message with a self-achiever? You want to stay on top of your health. You want to be in charge, keep the upper hand, acknowledge that the priority juggler is having a busy day. If the physical pharmacy's actually close by, remind them of that, but say, fit this into your schedule because it's important for you and your family, and remind them about that. The willful endurer doesn't want to think about this generally, but they don't want a health problem to interrupt their day. They're focused on having a great day to day, so remind them of that. And then balance seekers like me, we believe we make good choices, so reinforcing that, said, oh yeah, I make good choices, and of course keeping up with my prescriptions is a good choice. So as simple as that is, it's remarkably effective, and we're able to drive those higher response rates. And this has been deployed in a variety of settings, from federally qualified health centers where we had a large English as a second language population, Medicaid, rural patient base, using psychographic infused messaging, reduced missed appointments by 22% and increased compliance around, diabetes and other chronic conditions by about 20%. The top right graph here is the TriHealth experience, where not just lifestyle improvement, but clinical measures are being improved. The spine surgery readmission rate here was dropped. This was Mass General in the Northeast, Boston area, from 6% to 1.5%. This was St. Thomas in Nashville. CHF readmissions reduced from 18.5% to about 2% after using psychographic messaging with an automated platform. And then in the urgent care clinic arm of healthcare, huge response rates to post-visit outreach, which is driving increased loyalty. Urgent care clinics have a much better play with willful endurers than traditional physician groups do. The willful endurers love the convenience of the clinic, so when they come in that door, to connect with them and keep them coming back has also upped their monthly collections and the net promoter score. So when you think about the financial impact to this federally qualified health center, this was, pushing close to $1 million a year. And you think about St. Thomas discharging 600 odd patients a year and moving from, where they were to where they are now is millions of dollars in savings against a very nominal cost. So you've got a substantial ROI, and these aren't high volumes, but they're high dollar values. So you think about the cascade of this across larger uses within broader health systems. This is a large Midwest system that analyzed patient data on about 90,000 inpatient admissions, and they distilled it down to what's the contribution margin by health personality segment. And this was a remarkable insight to realize that the priority jugglers and the self-achievers, so this is a mixed category, this is a proactive category, had significantly higher contribution margin than these other segments here, and also fewer admissions versus these segments that had more admissions. The average length of stay was 2 to 3 days less for these segments than these. So strategically, they're now pivoting to focus on acquiring more self-achievers and priority jugglers as new patients in their marketing efforts. And I'll talk about how we're able to identify the population at large that they're going to use to do that with, and refocusing their population health efforts towards these less profitable, less optimized resource utilizers that are the willful endurers in particular and direction takers, and saying we need to plug more population health effort towards these less optimized resource utilizer segments. So to go a little deeper, this same system was also looking at income levels. So you can see here, it's interesting that under 15,000, there's virtually no priority jugglers on this end of the scale. About half of them are up to 100,000, and over half of them in this patient population were over $100,000, followed by the self-achievers, then the balance seekers, willful endurers, and direction takers. So this was quite an interesting thing. The self-achievers and balance seekers being proactive they believe in spending money today in order to have better health tomorrow. Self-achievers in particular also are very focused on feeling good in appearance. They are the participants in wellness programs at the corporate level, and you see imagery of them jogging on the beach at sunrise or doing yoga or sitting in a locker room with a towel wrapped around their neck after they've worked out. Well, they have the disposable income to spend on higher margin optional services. The mix of patients by type of coverage was pretty interesting as well. And so when we think about Medicaid, commercial, and Medicare, and we know who's falling into these segments, that provides new insight for strategic patient engagement. And then when you look at geocentric, knowing we're trying to attract willful endurers towards an urgent care clinic, when we know where the location of that clinic is and we can heat map the population by segment, that then can inform digital outreach campaigns for patient acquisition and loyalty. And then using psychographic messaging has substantially increased response rates, click-through rates in the digital campaign from about 5% to 10% to 15%. And those are significant numbers to traditional outreach and response rates that we've seen before. So to do these kinds of projects, there's an approach that we've been using to get to proof of concept so that we can do this in a low cost, relatively rapid turnaround, minimal change environment. We take a patient record file and append the health personality segment data field to those records. So thinking back to the national statistical projection, we're able to take first name, last name, date of birth, home address, city, state, zip, gender. That's all we need. We'll bump it up against this one database that's licensed this capability, built the algorithm to project the segment onto the whole adult population, and we'll turn that file around in less than 2 weeks, and then can start doing analysis on engagement data, now being able to slice that by health personality segment. Cost data now being sliced by health personality segment, condition data, compliance data, risk data, et cetera. So these are just some generic KPIs that are out there on the web, and coming from an orientation of how do we save money for most of my career, I focus right in on costs. So we see costs by age group, and we know older people tend to cost more. We also know that the self-achiever segment has a much higher average age than the willful endurer segment, usually by 13 to 15 years difference on average between the self-achievers, more baby boomers, and the willful endurers, more millennials. But if you think about pulling out cost data by health personality segment and moving beyond what we know for the average on all patients to what we now may know by health personality segment, that allows us then to do a far more targeted campaign for which patients we believe now we can improve our underperforming KPIs, the top KPIs that we're trying to move the needle on, which generally are, well, many of them are being driven by getting more people into the front door of the process or the office, and then getting them to take action on it, and ultimately to achieve and sustain health improvement, whether that's on the lifestyle side or the clinical side. And with that, then we can take existing messaging, create 5 different versions of that message that we infuse with those psychographic keywords and key phrases that connect to those human beings far more readily than the one-size-fits-all approach. And whatever outreach modalities may be in place at that time, we could just use those, train the people around this particular demonstration project approach, so we can maintain a low-cost, high-value, fast turnaround with minimal amount of change, and not an enterprise-level commitment where we're going to have to go through redrafting roles and processes and upgrading technology. But longer term, we actually do have a technology platform that's been built specifically to deliver 5 different versions of the message to these patients in a sequenced workflow with multiple communication modalities. So we may send an email on the front end that's got a lot of information to a balance seeker, whereas we might just send a text message on the front end to a willful endurer, encouraging them to do something to continue to have a good day today, something that they're not going to dismiss just because it's long. And one of the challenges a lot of people have is they're trying to cram so much information into the communication pieces so that people have a full understanding. Well, that works really well for a balance seeker. And I want that as a balance seeker. To some degree, self-achievers, they're interested, but they're going to scan through that. They don't want that level of detail. Priority jugglers and willful endurers for sure don't want the level of detail. And direction takers will tend to get overwhelmed a little quicker than the others, and they just want to go to the doctor and say, look, I get it. You know all this. You're the expert. Tell me what to do. So the platform then allows us to migrate from proof of concept, where we've already demonstrated we can move the needle, to now how do we consider automation and scaling. So at this point, I'd like to get a better sense of the audience before we move into Q&A of what KPIs your clients are telling you are their biggest pain points. So if we can launch that poll there. And we just put a few in here. If you've got some others that you're hearing about you'd like some perspective on, please type it into the chat box. But really interested in, which of these are you hearing the most about most recently from your clients and any prospective projects you'll be working on, about what their concerns are. And I think this will tell us to some degree how we can move into Q&A here towards the end. So this is pretty evenly mixed so far. I've been hearing a lot about patient acquisition and loyalty. The patient experience, of course, is key to the acquisition and loyalty. Engagement, a little less. Quality measure improvement, of course, those go to the risk contracts, net promoter score. So fairly evenly. Do we have any more respondees here? We've got about 30, about half of the group is responding. I'll give it just a couple more seconds, and then we'll close the poll, share the results. Okay, I'm going to go ahead and do that and share results. So we see patient experience is the top one, and then evenly split with acquisition, loyalty, quality measure improvement, satisfaction, patient engagement a little further down than I might have thought, and the contribution margin. That's not necessarily going to be the top item on the list, but it's certainly one that is being looked at by the C-suite. Okay, so let's move into Q&A. I certainly want to be respectful of everybody's time. I hope this has been useful. And so we'll look at, what current programs and needs you're seeing in the market, and talk about any of the KPIs or any other questions you may like us to address. Thank you.
Yeah, thanks, Mark. I want to say there is a lot of interest in this topic, and we do have time for 3 to 4 questions. The one that I'd like to start with that came in is, are there other psychographic or clinical models that are in play in the market? And if so, how do you leverage the power of that?
Sure. There have been a number of psychographic segmentation models built over the years. The vast majority of them have not been deployed in healthcare, although there are some that have been around 20, 25 years. But the majority of the market today in healthcare is not using segmentation for patient communications, engagement, or even analytics. And I think because it's so rare these days that those older models have persisted and this newer model has come on the scene just within the past few years, we've got, a couple of million plus patients that have run through some use of this, whether in pilot projects or ongoing production efforts. But to leverage the psychographic model, we've got to know what segment the person is. So either using a patient record file to do analytics at a large scale to better understand our patient targets, and then modifying campaigns based on what insights we glean from those analytics is where I think the biggest impact can be made in the shortest period of time. Over time, we'll want to try to get the 12-question classifier answered by a patient, which is going to be hard if we already struggle to get them in the door. But once we've got them in the door by using the data-based statistical projection, we can confirm the segment accuracy or upgrade the segment accuracy to that 90+% level by using that classifier. And from there, it's redrafting and consistently sending out messages that connect to people based on their values, and then also training the staff to understand those psychographic insights. So when they're talking with them live face-to-face or on the phone, they've got a sense of how to connect to that. Terry Hanlon was saying at TriHealth that when they first tried that out, their nurse coaches are used to motivational interviewing, which is a common behavioral science technique heavily used in the wellness industry, and then also in kind of the health management side of the healthcare industry. And they were reporting that using motivational interviewing, it still took them 2, 3, 4 sessions with a patient to build that level of rapport that really yielded a successful ongoing patient engagement experience and got to clinical stability and cost stability. And by using the psychographics, they were able to do that sometimes in the first session, almost always by the end of the second, and that's why they rolled it out. So both the digital and print messages that are being sent to the patient, as well as training of the individuals who interact with the patient at the clinical level, even the staff level for administrative functions, can be helpful as well.
So one question that's also come in is, what has physician engagement and acceptance been with this sort of an approach? Can you talk to that?
Sure. Again, the group that built the model, I work with them as an independent consultant, much like all of us on the call here, and it's new to most people that they've talked with. And when we're talking about the urgent care clinic side of the equation, those business entities tend to be a little more nimble than large health systems. And so moving through the process of demonstration to what I call production or enterprise deployment level it's been going on for several years now, and they're starting to finally have made it through the C-level stakeholders that range from the chief clinical officer, medical officer, financial officer, patient experience officer, whatever it may be, at some of these larger health systems. For example, St. Thomas is part of the Ascension entity. And so moving beyond St. Thomas has been, it's a long, slow process, but the deployments have worked and the data is strong. And so we're continuing to see that this large Midwest health system that I shared some of the data on here is embracing it fully and focused on patient acquisition and loyalty is kind of the next stage of deployment, that they're wanting to acquire more of those priority jugglers and self-achievers, and they're retooling their clinical engagement strategies to infuse those processes with psychographics. So we're on the upswing there, and I'm also using this. I have a lot of employer and benefit consultant health plan clients and prospects that I've been working with, and we're trying to kind of bridge between the health system and the health plan and the employer and the health services, wellness and disease management companies, because they're all intertwined. And we just did an open enrollment project where we got more enrollment than they expected using this. So
and I'm glad that you brought that up. One of the questions that came in is, can you speak to how this can be used to design employee benefit programs? So could you expand on that a little bit for us, Mark?
Yes. Whoever asked that question, I'll send you the $20. That's right up my alley.
Here. We're going to hold you to that. Yep.
Yeah. Thank you. So I got into the benefits consulting business in Dallas back in the 80s, and by the end of the 90s, we were routinely delivering, 20 and 30% rate increases, and it was so frustrating. And when I found wellness programs and decided those had a better chance of saving money, I went full time into wellness, did that for 16 plus years. And the challenge with wellness and disease management is engagement. And the upper limit problem for virtually every employer in the country, with some notable exceptions, but most of them are not more than 50% of their employees ever participate in the wellness program. So with this open enrollment project that I just worked on, we're just now starting to get into the analytics, but we had about 5,000 employees. We worked with the total rewards department. We got an eligibility file, bumped it up against our database. We matched about 70% of the records, which is a little less than I hoped for, but the population has a lot of lower income and more high turnover, and they move around more, so it's harder to match off of home address. But the average age of the records we didn't match were younger than the average age of the willful endurers, which was the lowest age segment. So we used that as a intelligent default. We worked with the benefits administration platform company, and we worked with the enrollment services firm. So this was a counselor assisted open enrollment project, and the enrollment firm sent out emails and text messages to all of the employees. We couldn't even send them through the corporate system because it's a healthcare entity, and IT wouldn't whitelist what HR wanted to do, which was to send emails to the company email addresses. So we used the personal email addresses and used Psychographics. So we rewrote the standard message for the emails, sent a wave of 4 or 5 emails, 2 or 3 texts over about a 4-week period, including 2 weeks before and 2 weeks during open enrollment. We had requests for enrollment interviews, 750 plus more interview requests than what everybody expected. So the enrollment counseling firm had to scramble a bit to supply the counselors to fill those slots, but they did it. And then we ended up with a 10 to 15% overall increase in core, which is health plan and dental and disability, core benefits enrollment, as well as voluntary benefits enrollment. So we're now taking the health personality segment data field, which is in all 3 systems, the employer, the ben admin, and the enrollment firm, and we're passing the data through to the TPA, the disability FMLA carrier, and we're talking with a couple of the other vendors for them to analyze some of the cost and compliance metrics on the medical and pharmaceutical claims data and on the disability absence and FMLA data. So that's an approach that is underway right now. We're also working with other providers in the employer and benefit space that provide things like digestive disorder intervention or sleep disorder intervention, or second opinion services where they need more people to use those services for them to work.
Fantastic. Well, thanks for those full circle examples. I wanted to move into market relevance. The question is, how relevant is the psychographic and targeting approach to other healthcare markets, such as veterinary medicine? What are your thoughts on that?
That's an interesting question. The model was specifically developed for medical and pharmaceutical healthcare services for humans, and the related employee benefits that are part of that, people's attitudes towards insurance and high deductible health plans and those kinds of things. It's been expanded and being used in the dental market with increasing presence there. Obviously, the urgent care clinic market. It's been used in a few other instances. We're talking with some groups about retirement products and financial products because financial wellness has become important. I don't have any awareness of specific use cases in the veterinary market per se, but the values of the human being inform their choices in the broader context of their lives to some degree. So I don't want to suggest it's usable for any purpose whatsoever, but because we're still talking about healthcare, even though it may be pets, there could be utility there, but I'm not aware of any specific use cases where it's been tested.
Yeah. Well,
so there is some extensibility, but not broad, not too broad.
Okay. So one question, as we think about how this can be used to drive down the cost of healthcare, topics like artificial intelligence, are really being talked about from a variety of angles. And earlier you talked about flexing the message to meet personas and being able to talk at the level that the consumer is expecting, to hear. So could you describe for us the use of AI and maybe even robotic processing automation in terms of driving change or reaching better outcomes?
Sure.
Is that viewed as kind of a next level enabler here? What are your thoughts?
I think the state of the market is that AI and machine learning and modifying clinical protocols is in its very early stages. It's certainly being looked at and tried, and a lot of people are working on it from a variety of standpoints. IBM and Watson Health has been looking at that. A number of large firms like WellTalk works with IBM Watson, and they have a huge database and are actively cultivating machine learning on how do people respond to recommendations that come from a recommendation engine that ingests all of the consumer data points. So they're looking at the priorities from what choices have been made in the past. The psychographics is more of we can use historical analytics as part of the classification process. But once we've got them classified, then we want to test how the response rates go and ingest the data from running these campaigns and tracking who's responding to what. And if we change, if we're talking about a balance seeker, what impact does the change of a phrase we're talking about choice have versus the impact of a phrase where we use the word options instead of choices, and things like that. So to my knowledge, all of that is in its infancy and would be a later stage enabler, but it's certainly on the roadmap.
Okay, one last question, and then I'm going to get ready to turn this back over to Mike. Can you speak to the challenges around activation of some of the insights that you shared today? Specifically, Mark, any of the limitations to joining patient and that marketing and commercial data that you described, to enable some of those targeted marketing behaviors or buys, if you will?
Sure. I hope that this answer's on point. I think I understand the thrust of the question. So, obviously, consumer data and privacy is a huge issue everywhere in the world today, and So I don't want to skip lightly over that foundational concern. HIPAA allows the sharing of PHI among stakeholders in a human being's health to the extent it's part of treatment, payment, and operations of a health plan, or someone is a covered entity. So physicians and hospitals and medical care providers are covered entities. Employers and health plans are business associates. Wellness companies are business associates. And I was the chief privacy officer for a wellness company based in Dallas for some years. So I'm fairly well versed in HIPAA law, and we are able to share that individual protected health information of any kind within the ecosystem allowed by HIPAA among and between shareholders without individual level authorization. Public data on our consumer patterns is, to some degree subject to terms of use on the websites where that data is being harvested. I, for one, am just like everyone else. I want to get something. They want me to accept the terms of use, and I glance at it and go, I'm not going to read all that, accept.
Mm-hmm.
So I've accepted an enormous number of terms of uses, and I really have no idea how my data is being used. I care about my privacy, but I kind of figured it was, beyond my control in any meaningful way as of years before I even realized it was. And I think most people feel that. And so some newer privacy constraints are coming in, and I think we need to be sensitive to that. But companies are selling data like that on a regular basis, and it is legal as long as you don't violate HIPAA and as long as you don't violate FTC protections. And so to acquire the data on a large group of patients, use it for analytics, and use it in a beneficent purpose, I believe for the most part is not going to cause problems. Some stakeholders want to work with the patient and have them know what their segment is, and some don't. They just want to use it to improve their own ability to connect with that patient. So I don't think that answers the full import of the question, but I hope it at least addresses some of the substance.
Well, I think we made the most of the time together today. So I just want to say we appreciate everyone's input and participation in the Q&A portion of this program. So Mike, back to you.
All right, thanks, Deb. Mark, I want to personally thank you very much for sharing your thoughts and insights with all of us today. Mark's contact information is on your screen if any of you have further questions for Mark. And you'll be receiving, as Jeci mentioned, a post-event survey in your inbox. I know the world is over-surveyed, but if you would please just take a brief moment to leave us your feedback, it'll help us make sure we're improving these healthcare practice events in the future. And of course, we would very much welcome any input you have for ideas, speakers, and topics as we continue to build this healthcare practice. I want to thank everybody for being an active member of the Patina Nation, and have a great rest of your day.
This has been a presentation of the Patina Nation. To watch more content like this or for more information, please visit us online at www.patinanation.com.